Welcome to Moving Medicine, a podcast by the American Medical Association. Today's episode will pick up part 2 of our conversation with immediate past chair of the AMA Board of Trustees, Dr. Willie Underwood. He's joined by a panel of experts to talk about the maternal health crisis in the U.S. and what can be done about it.
Thank you. I got to tell you, the work that the AMA is doing in our DC office regarding policy, working with the White House, working with regulatory agencies to address these issues. The work that we're doing in Chicago, what Mike is doing around the hypertension disorders and trying to move this forward. The things that Maryanne has talked about, the mental health and moving forward. But to do this, we have to have a physician workforce that has the resources and the tools that it needs to be able to implement this great policy and put these great programs together. And that Jennifer hard work in DC and other folks in DC, that we're able to reach the goal of eliminating those 80% unnecessary preventable maternal deaths. So Maryanne, what is the current landscape of maternal health physician workforce? What policy changes do you think need to be implemented to support the maternal health physician workforce and ensure that patients everywhere have access to high quality obstetric care?
Yeah, so what does the maternal health physician workforce landscape look like? I'll share it's concerning. And I'd like to share some data, but then also some solutions that are going forward to address it. So in 2023, the number of medical student residency applications dropped in the relevant specialties that would deliver babies. We saw a 3% drop in family medicine residency applications, a 5% drop in OBGYN applications, and a 21% drop in emergency medical applications. And to add to this, the burnout rate among physicians in these specialties hovers around 60%. Furthermore, ACOG projects that there will be a shortage of up to 22,000 OBGYNs by 2050. These statistics are not sustainable if we are to improve maternal care and health outcomes in our country. So to answer your question, Willie, on what specific advocacy policy changes are needed to avert this impending maternal workforce crisis, I'd say we need a greater focus, a focus on increasing and retaining the number of physicians in maternal care to decrease maternal care deserts and improve health outcomes. There are a number of innovative ways to start positive changes for the future and help improve the training and retention of physicians who provide maternal care. There are 5 workforce advocacy items that we at the AMA are urging the administration to action to improve access for maternal care right now. The first advocacy action is to expand maternal care education and training, especially for those physicians that are likely to give care to pregnant or postpartum individuals, but are not OBGYNs or maternal fetal medicine specialists. The second advocacy action is to increase funding for teaching health center graduate medical education, or the THC-GME programs. These programs are important, and they support the training of resident physicians in community-based ambulatory care centers. And the programs prepare physicians to provide high-quality care and serve diverse populations in our rural and underserved communities. Since 2010, this program has helped 21 OBGYNs complete their residency and then enter the workforce to serve. Though this is an excellent start, an additional funding is needed and support for this program is needed, in particular for OBGYN training. The third advocacy action is to increase funding for the National Health Service Corps and ensure that a higher percentage of physicians are accepted to the National Health Service Corps loan repayment programs and scholarship programs. Personally, as someone who participated in a similar program, the Health Profession Scholarship Program, or HPSP, through the Department of Defense, I can't begin to tell you how essential that support was, that program was, to enable me to attend medical school and then serve my country. The fourth is to increase compensation for Indian Health Service physicians to a level that's competitive and equitable with other federal agencies. And additional funding should be provided to the IHS loan repayment program to increase the number of physicians that can be supported to serve these marginalized patient populations, especially in the maternal care space. And the final action is to allocate additional funding for the Indian Health Services Maternal Health Program. And this program should then ensure that the funds it receives are used to increase access to OBGYNs and maternal fetal medicine specialists for American Indian and Alaskan Native pregnant individuals. Many solutions there, Willie.
Yes, and we have to move them all forward. Now, here's a question that I often receive. I often receive the question, Willie, with all the stuff that physicians have to worry about, why are we talking about things like this? Why are we talking about substance use disorders in pregnancy, hypertension in pregnancy, social determinants of health, discrimination, inequities in healthcare, and all these other things? Why should we focus on that? Why? Because these are things that impact the very people who we set out to serve. But not only that, they cost our nation huge financial costs, but not only that, the cost of loved ones, because we're all, as me as who I am a son, I am a brother, I am a cousin, I am an uncle, I'm all these other things as well as physician. And I see the impact that this has on the families and on my personal family as well. So this is why the AMA is in this space, so that we can improve the health and the healthcare of the nation. And this is a major problem. It behoves us. They look at us if we have 80%, right, preventable deaths, and if we don't stand up and solve that, someone else will, and most likely will not be in our best benefit. That's why we need all of us, all physicians on deck, all medical organizations on deck. And this is a priority for us, as well as many other priorities. So having said that, Maryanne, what are some ways we can advocate for maternal health at the state and local level?
So you mentioned advocacy and how important it is to medical care, and I completely agree with everything that you have said. Healthcare advocacy is very powerful, right? It uses data and recognizes the connection between patients and community health, and the social determinants of health and the structural systems that influence health. It's really another indirect way, perhaps, in which we care for patients. It can be done individually, as occurs often in our own practices. An example comes to my mind recently when I was working to obtain a prior auth for an MRI for a patient, and I spent almost 30 minutes on the phone trying to inform and persuade a benefits manager to change a policy so that my patient could obtain the study. So we do this individually, but on a broader scale, advocacy can be even stronger when it's done strategically and has the support of organizations or groups that can help influence change improvements and assist, especially with lobbying. When advocating specifically for maternal health, as we're talking about at the state or locally, I would recommend that advocates get involved and network and collaborate with state medical societies, specialty groups, get involved with state and local organizations that are focused on maternal health, such as the PNQINs, the Perinatal Neonatal Quality Improvement Networks, and the state and local departments of public health, and with state and quality and safety organizations. And in my state, for example, we have the Betsy Lehman Center, the Mass Consortium, Coalition for the Prevention of Medical Errors, Mass Health Quality Partners, and others. Many of these organizations you can work with them and collaborate with them to effect change. Because maternal advocacy, it really needs to crosswalk with collaborators whenever possible to achieve the best outcomes. And supporting advocacy is so important to improve health and healthcare in maternal health. And I strongly believe it is so vital that advocacy education and involvement should even be part of medical training and included in considerations for academic promotions going forward.
Thank you. Jennifer, what are some ways that medical students can make an impact with this issue?
So that's a great question. I talked briefly about the medical legal partnerships at the law schools and the medical schools. But I also want to talk about, and this is a very elementary kind of concept, but it's critical. And that is taking time to stay in the moment with the patient in front of you and listening. The CDC has a national campaign called the Hear Her campaign. The focus is to ensure that birthing people and their families know what warning signs to look for and to be able to communicate that with their physicians and their healthcare providers. But it also involves active listening on the provider side. And Maryanne talked about the burnout rate for physicians and certain specialties. And so we're talking about ER physicians, we're talking about family physicians, we're talking about OB-GYNs. And so they have the highest burnout rates. And so it's really important when you're exhausted and you're burnt out and you're dealing with other things that are going on in the hospital setting to be able to just take a moment and stay in the moment. So I'd encourage the medical students to do that as well and focus on that. That's kind of a skill, an active listening skill, but also staying connected with your state and federal public officials. Maryanne talked about it briefly, but as you all know, we work collaboratively in advocacy. I work with my colleagues who are attorneys in the Advocacy Resource Center to navigate these spaces at the state level and with the state medical societies. We also work here in the DC office with our federal affairs lobbyists and our congressional lobbyists. So getting involved at the state and federal levels, knowing your members of Congress, knowing who represents your district, and being able to serve as a resource is key to moving this work forward. The other thing that I wanted to add that we are we have produced a larger document that's about 30 pages that really details this work that we've been doing and does a sort of a deep dive into our recommendations that we've produced and sent forth on policy recommendations at the state and federal level. We're really trying to make sure that we elevate all the great work that is being done across the AMA. And that will also help medical students and others to kind of understand where we are and what they can do and what legislation, what amicus briefs, what's going on, and we'll continue to update that and to keep them apprised of the path forward.
Michael, so what are some solutions the AMA Improving Health Outcomes Unit has to develop to help physicians and care teams improve blood pressure control? And also add this to it, what are some key pieces of education to share with patients diagnosed with hypertension in pregnancy, the hypertension disorder of pregnancy?
Well, our team, the Improving Health Outcomes team, is really focused on hypertension throughout all phases of, for adults in the United States. We have a portfolio of solutions that focus on helping improve the quality of care, provided to patients with hypertension and to improve blood pressure control across all of these phases. I'll mention three briefly here. Our AMA MAP hypertension program is a data-driven quality improvement program that focuses on the accurate measurement of blood pressure, timely and effective treatment, supporting patients to self-manage their hypertension. And all of this is done with a team-based approach across multiple disciplines. We've got the AMA MAP SMBP, which is a practical 7-step approach for using home blood pressure monitoring to effectively lower blood pressure and improve blood pressure control, because that doesn't happen if you just hand out blood pressure monitors. That really needs to be done in a specific way to really see the improvement that we want to see. And finally, just the third one is the US Blood Pressure Validated Device List, a website, validatebp.org, that lists devices that meet rigorous criteria for being validated for clinical use, including a subset of those devices that are validated for use in pregnancy. The second part of that question, some key pieces of education to share with patients diagnosed with hypertensive disorders of pregnancy. Know your blood pressure numbers, and know what your treatment plan is. That includes both antihypertensive medications and aspirin if they're being used, or implementing the positive lifestyle changes that I reviewed earlier. Knowing the warning signs and symptoms and what to do if you experience them. Understand that your risk continues postpartum, and understand that your future risk of hypertension and cardiovascular disease is higher, and the absolute critical importance of following up with a primary care physician and any other healthcare professionals who help manage postpartum health long term.
Oh, thank you. So as noted, effective treatment and prevention of consequences of depression through an antepartum and postpartum depends on access to immediate treatment. Most areas have long waiting period, especially those in economically and geographically disadvantaged areas, I think. Can nationally based telehealth access overcomes these obstacles? So I'm going to open this up to the group.
Sure, I can start. I think telehealth is incredibly important in providing any kind of mental health, behavioral health care for patients in pregnancy and not during pregnancy. I know for example, I'm in Massachusetts. In Massachusetts, we have programs for where primary OB practices or others who have a patient with symptoms of postpartum depression can call into McPack for Moms number and get help immediately to be able to treat that person while in the office or closely after the time that they're seen in the office. So I think telehealth has tremendous, we need it because there is such a lack of services for behavioral and mental health care and substance use. So it is critical to have that available. It's wonderful to integrate behavioral health into practices, but where that can't occur or cannot optimally occur for the patients populations being served, then telehealth serves an incredibly important function to be able to have access to that care, especially as we have maternal care deserts actually increasing in our country at this time.
Yeah, and I want to add to that and just say, regarding the maternal health deserts, I know you touched on it and the impending worsening crisis and what's happening with the OBGYNs and access to care. But currently, right now, where telehealth could absolutely make a difference, 36% of counties in the United States do not have a practicing OBGYN, do not have a hospital to deliver babies, and do not have birthing centers that do that. So while telehealth won't solve all of those issues, that's a huge percentage of the United States that could benefit from telehealth to improve the quality of care where there isn't care. In addition, in addition to the factors like transportation and for people who work, basically access issues, for people that you could tremendously benefit from having more ubiquitous telehealth available.
One of the things, if I could just chime in briefly, that we're doing at the federal level is that we are really pushing for reliable broadband connections at both the site of the physician and the patient to ensure that there's consistent, reliable maternal care that can be provided as well. And so I just wanted to elevate that work that we're doing, both on the telehealth front, but particularly talking about broadband connections.
And just to add to that a point, and I don't think we have time to discuss it, but I guess there were 610 medical students who applied to OBGYN programs this year that did not batch. And I know the AMA is working diligently to increase residency spots with CMS and other programs, not just for OBGYN, but across the board. But by increasing those programs, we can hopefully impact the problem that Michael just laid out with all these areas of the country not having access to care in this area. Now, having said that, we're going to try to wrap this up quickly. I would like, and we're going to go with, again, Jennifer, Michael, Maryanne, give some closing remarks and take-home statements that we want our audience to remember.
I think the one thing that I would want people to remember from this is that this is our This is a major first step for the AMA to continue to move this work and to elevate it at the state and federal levels. But this is our first kind of step forward in this space, and we will continue this work, continue meeting with the administration, continue our work lobbying on the Hill, continue meeting with state officials. We have interviewed both state surgeon generals, perinatal quality collaborative folks from hospital systems in urban areas that have high Medicaid populations. And so we will continue to do this work, continue to find recommendations, continue to elevate those with our federal government and state government officials. And we just want to focus people back on our maternal health website so that people have resources on our work as we continue this important and critical work and a path forward.
Michael.
Most maternal deaths are preventable. We can do better by supporting physicians to optimize patients' cardiovascular health in all phases of life, including pregnancy and postpartum. And for hypertensive disorders of pregnancy specifically, implementing best practices for treatment of people with these disorders, including AIM patient safety bundles, emphasize and improve continuity of care in the postpartum period, ensure long-term medical care for patients with these disorders, including continued screening for cardiovascular disease and its risk factors, and supporting patients by making telehealth and remote physiologic monitoring available, improving coverage and access to clinically validated BP devices and cuffs to support home blood pressure monitoring, increasing patient awareness about the risks and need for continued follow-up for medical care after pregnancy, making sure people know how to optimize their cardiovascular health before, during, and after pregnancy, and promoting programs like the Release the Pressure program to partner with Black women to support their heart health.
Maryanne, you got the last few seconds.
Thank you. So I would just say, please stay active. Please stay involved. Please keep advocating for all of the issues that you've heard about today. They're all so important. We can do this. We can decrease maternal mortality in this country. We can solve these problems. There have been absolutely excellent action items discussed today, and I'm sure there are many more that have to be discussed and can be thought of by all of you going forward. But it is really, really important that we do this, that we recognize this issue, and that we take interest and action to change it, because it can happen. So thank you, Willie.
All right. Until then, God bless, and thank you very much for joining us. Please join us in our efforts. Please support the AMA. Please use this information, and let's fix this problem, because we can, we will, and we must. Thank you. God bless.
Subscribe to Moving Medicine today. Thanks for listening.